Good evening. It is a great pleasure to meet you again within our cycle of programs concerning entitled Nighty Talks About Lipids. So today, the last meeting, as you remember, during the last meeting we discussed about the role of nutraceuticals in lipid-lowering management on the example of radius tries, on which we presented based on the newest recommendation of the International Lipid Expert Panel. And today I would like to discuss you a little bit more about the statin intolerance. It is probably one of the most debatable issues, the reason that we are not adherent, and the reason that even 40 to 50% of our patients can discontinue statin therapy after 1 to 2 years. What is more, we know it very well that in the media, in the social media, in the internet, there is even 7 to 10 times more information about the potential harmful effects of statin therapy and lipid-lowering therapy, but especially statin therapy in comparison to those highly recognized beneficial effects of statin therapy. So this is something we need to discuss. That is something I would like to educate you, because we have enough knowledge to treat even 98% of patients with statin therapy without any safety concerns. So let's start. I've prepared a few documents I would like to share with you. So if you allow me, I will start, because we have a lot to discuss today. So first of all, I would like to invite you for the special issues. I am the guest editor of it. This anniversary special issue of Journal of Clinical Medicine. This is impact factor almost 5 on statin intolerance. So if you have data, especially real world data, it is critically important for me, within which we might discuss the prevalence, the risk factors, the conditions that might increase the risk, the management, and many other different issues. Please submit your data, but obviously all other issues associated with statin therapy, please feel welcome. I'm awaiting your submissions, because I do believe that within such a special issues we can have a very effective education about this, and and this education is critically important concerning, and it should be and we should focus not only on physicians, but we should focus on nurses, on the emergency personnel, as well as patients. Because if we have patients that will believe in statin, we believe in beneficial effects of statin, there will be no problem of non-adherence. So this more, I would like to invite you to read this paper. It is a beautiful paper, invited review in cardiovascular research we published a few months ago. When you have every information, you will find this very detailed information on the potential mechanism, the background of statin intolerance. You will find all the information on the possible side effects, but please remember, we have only 3 causal statin-associated adverse effects. These are statin-associated muscle syndrome. These are temporal elevation, especially of the aminotransferase alanine, and we have new onset diabetes. There is no other causal effects concerning statin therapy, and I'm completely against the issues which was raised in one of the documents of the European Atherosclerosis Society concerning the lens concern, and because there is no clinical relevance, and we should not focus at all on this. You have also all the information about the definition, which is critically important, as well as what is the potential clinical potential mechanism and what is the clinical relevance, as well as critically important issue on the drug-to-drug information. All these you can easily find in this document. Please feel welcome to read this paper. What is more, if you have any doubts concerning very low level of LDL cholesterol or extremely low levels, and the risk of potential hemorrhagic stroke, and whether there's any link between statin therapy and hemorrhagic stroke, please feel welcome to read our paper we published in Brand Journal with Pierre, with Dennis, and Chris, Professor Chris Cannon, and you will find also all the information. But I can tell you now, don't think about the hemorrhagic stroke, don't think about the statin intolerance while you are starting statin therapy, because it is the biggest mistake, and it is one of the most common reason you will be not effective. It is the most common reason you will be the cause of the physical inertia and non-optimal statin therapy for your patients. So that is why don't think about the statin and potential statin associated adverse effects while you are starting statin therapy. And there is no link between statin therapy and hemorrhagic stroke. Forget it. Simply forget it. And we have enough data in order to be sure of it. Okay. This is something I would like to share with you at the very beginning, but I would like to focus with you on our guidelines we presented within the International Lipid Expert Panel. As you can see, within a very experienced group of authors with Peter, with Eric Brucker, with David Moraes, with Zlatko Reiner, with John Mancini from Canada, from Peter Todd, and many other different Dimitri Michailidis and great experts from all over the world, in this paper, within these recommendations, we wanted to first of all to say what should be the clinical message and clinical pathway in patients with different statin-associated adverse effects or different symptoms, and usually as a step-by-step recommendation, a step-by-step pathway, and how we may and whether it is possible to overcome the so-called nocebo-rocebo effect. You know it very well. What is the nocebo-rocebo effect? The nocebo effect is a psychological approach that we will have statin-associated muscle symptoms after statin therapy, but it is only psychological approach. These are not real symptoms associated with statin therapy, so there is no causal effect. And you should remember now, we know in 2022, in September, that even 90% of all statin-associated muscle symptoms, statin-associated statin intolerance issues or cases are due to nocebo or rocebo effect. Or we are discussing nocebo-rocebo effect because we strongly believe within ILAB, and there is not only belief, but even sureness, that a nocebo effect is incorrect, because as you can see, nocebo effect is usually associated with no treatment or with inert tablet, but only when our patients are treated with drug or blinded with drug, so with statin, or with blinded drugs. So the patients might think that there is a statin without any 100% being sure of it. It is nocebo effect because it is strictly associated with the effective treatment with statin therapy. So that is why a nocebo effect is incorrect statement. But due to the fact that we don't want to make any chaos, we simply much prefer using nocebo-rocebo effect in order to avoid the situation that for some of you to have an chaos with this statement. But it is critically important. So that is why we wanted within this paper for the first time to discuss how to overcome it and how to be very effective with statin therapy. As you can see, first of all, we've made a kind of a summary of the available definitions. It is critically important because, from one hand, you need to remember that statin intolerance is simply it is simply a lack of possibility of using suitable dose of statin, taking into account the patient's risk classification, risk group. So, for example, in patients after acute coronary syndrome, the patients should use rosuvastatin 20-40 milligrams or atorvastatin 40-80. If these patients cannot tolerate these doses, it is also statin intolerance, but obviously partial. If these patients cannot tolerate any dose, it is complete statin intolerance. And we have different attempts since 2014 with National Lipid Association, and with the very recent recommendations and papers, expert opinion papers, and I would like to using these occasions, I would like to thank the National Lipid Association for a very active work on the statin intolerance issues, because it is critically important, but also International Lipid Expert Panel and other groups that trying to have these definitions very practical. But as you can see, these are very complicated definitions, but we should remember that it needs to be a kind of attempt, first of all, to use at least 2 statins, with the second statin uses which is applied with the lowest possible dose, it needs to be associated with confirmed symptoms. So after exclusion of the other risk factors and conditions that might increase the risk. And if possible, we should also see whether it is associated with the increase of the biochemical changes of especially creatine kinase, and we should also exclude drug-to-drug interactions. Please remember about those few issues, and I believe it will be completely enough. What is more, if we look at the concrete guidelines, first of all, please notice how we may overcome the nocebo-racebo effect. First of all, it is something which is called PLIP, patient-centered discussion about benefits and potential. It's provision and personalized lipid intervention plan. So let's go to this PLIP in order to let you understand how it is important. If your patient is convinced that statin therapy is effective, is convinced that statin therapy will be associated with the prolongation of his life, with the reduction of the cardiovascular outcomes, there will be no problem in order to continue statin therapy. That is why the patient needs to know, why have I been prescribed lipid-lowering medicine? So we need to talk about the disease. We need to talk about what kind of drugs and group of drugs we are talking about. What is more, how should I take my medicine? It's critically important to discuss with the patient and why statins usually we take in the evening or when there is a polypill with ezetimibe, and I would like to strongly recommend polypills with ezetimibe. It doesn't matter when the patients take it. How will this treatment benefit me? It is critically important. If the patient is convinced that it is beneficial, there will be no problem, even with some pains, even with the temporary elevation of the aminotransferase alanine. The patients will continue it and there will be no problem with this. How will I know the medicine is working? So let's try to educate our patients that it is associated with the effective lowering of LDL cholesterol. What side effects should I expect? It is also important. The patients need to be informed that there are some side effects after statin, but also after all other drugs. And in fact, statins are probably one of the group of drugs in cardiology which is associated with the lowest risk of side effects in comparison to ACE inhibitors, in comparison to CCB, calcium channel blockers, sartans, and few others. So it is critically important, as well as many other issues associated with lifestyle changes and so on. Please find your time for this education, because without it, we will lose our patients, and we will have more and more patients being not adherent. What is more, we should focus on the other algorithm we also introduced. It is MEDS algorithm. So MEDS approach to statin-associated symptoms. So we should do our best in order to minimize disruption to lipid-lowering therapy. We should continue education and counseling. We should talk about the different non-pharmacological approaches, how to be effective with the reduction of the LDL cholesterol, and about different symptoms and biomarkers, and then have a SLAP algorithm, how to overcome and how to be effective with treatment. So we may switch statins. Please remember, we have new statin finally on the European market, pitavastatin, for which obviously take into account some limitations associated with the relatively low data in comparison to atorvastatin, rosuvastatin, and simvastatin, but it is associated with the lowest prevalence of statin intolerance after pitavastatin, which is comparable to placebo. It is the same with new onset diabetes, which we after pitavastatin we may even observe the improvement of the carbohydrates metabolism and glucose and hemoglobin A1C and so on. We may lower the dose, but here with the lower the dose, please always consider combination therapy with ezetimibe, with the polypill, because then patients will not recognize, for many situations, despite the fact that the patient is informed that this is still statin with ezetimibe, but for him, for many of those patients, it's a new drug, and the patient does not recognize it's a real statin. And polypharmacy with non-statin therapy, including, as you can see, bempedoic acid, including some of the evidence-based nutraceuticals, PCSK9 targeted therapy approach, or with inclisiran and PCSK9 antibodies. Okay. What about some critical issues concerning the new onset diabetes. Please have a look. Here in these guidelines, for the first time, you have a very clear information with the class and level of recommendation how to proceed with new onset diabetes. If new onset diabetes occurs, it is recommended to continue statin therapy. We know it very well that it's 5 times less. That benefits much outweigh the risk by 5 times in the secondary prevention, 3 times in the primary prevention. In patients at the risk of developing new onset diabetes, moderate intensity statin therapy and combination therapy, depending on the risk, may be considered. So we suggest that obviously there is an expert opinion, 2BC class of recommendation, with different patients at the risk of diabetes. So the elderly patients, patients with obesity, metabolic syndrome, and so on. We may consider, if you have a baseline level of LDL cholesterol and risk classification of your patients, and you know what is the expected level of reduction of the LDL cholesterol, start with combination therapy, because then you have a lower dose of statin. So the risk of new onset diabetes for the intensity statin therapy is decreased, and we have ezetimibe. Finally, all individuals on statin who have major risk factors for not particularly impaired should be informed about the risk and monitor for hyperglycemia. It is quite normal. What about the aminotransferase elevation, aminotransfer alanine elevation? For all those with increase less than 3 upper limit of normal, statin should be continued. Obviously, those patients should be monitored. But in all those with the higher level than 3 times more upper limit of normal, statin therapy at lower dose, step-by-step challenge, not discontinuation. Forget about the discontinuation, may be considered. Ezetimibe should be immediately started, but please remember that in 97% of those patients, when we have an elevation over 3 times upper limit of normal, after 4 to 6 weeks, you can come back to the baseline level, baseline doses of statin therapy. It is the same with creatine kinase. As you can see below 4, because we strongly believe that this cutoff point of 4 is probably the most important. You can see that if intolerable muscle pain occurs, discontinue therapy, but only for 2 to 4 weeks until symptoms have resolved, and then you can start with re-challenge. Immediately start ezetimibe. It is critically important not to wait with other drugs. Why? Because if you have your patients that very high, extremely high cardiovascular risk, if you discontinue statin therapy for 4 to 6 weeks, as it is in the previous 2015 European guidelines, you will have instabilization of the atheroma plaque and the very high risk of recurrent cardiovascular events. Okay, what about in those patients over 4? Over 4, we should stop statin for sure, because it is the risk of myopathy, myonecrosis, and rhabdomyolysis. But statin with challenge at the lower dose or combination therapy, I would like to once again emphasize the role of combination therapy should be considered, and SLAP algorithm should be obviously recommended in all those patients. What is more, please have a look that we probably here show you all the possible other secondary reasons of CK elevation that should be excluded, because then if you have your patients with CK elevation which is associated with other reasons, then you may cause harm due to the lack of statin therapy in your patients. And then there are also some other recommendations in those patients with SAMs with CK elevation over 10, and here you have a kind of summary of the most important recommendations concerning statin therapy. This is a very step-by-step approach how to proceed and how to be effective. And please have a look that we are talking about the new drugs with bempedoic acid, combination therapy, fixed dose combination of bempedoic acid and ezetimibe with inclisiran, all those drugs that are already available, despite the fact that they are still not recommended, not reimbursed in many countries, but we still believe that this year might be critical for all those patients that that may have finally those drugs reimbursing even in those countries like Poland and Central Eastern European countries. So once again, please look at this paper, because you will find in this recommendation all the most important issue, how to be effective. After this paper, you will read this paper. I am very sure that you will be effective in 97%, 98% of your patients, and those patients will be still treated with statin therapy. Okay, what next? You know probably that during the European Society of Cardiology Congress, the new CTT collaboration analysis was published, and this is a great concern for me, because I discussed this paper widely with the authors as well as with many other experts, and we should treat this paper very and we should read this paper very carefully, and we should we should make conclusions based on the paper with some concerns. First of all, this is the patients' data meta-analysis from 19 randomized controlled trials evaluating statin therapy versus placebo, and four additional trials in which high intensity versus low to moderate intensity statin therapy were evaluated. As you can see, 19 placebo-controlled trials, mean age 36 years, and altogether even 48 patients were with vascular disease, 18.5% of patients with diabetes. So these were mainly very high-risk patients. Mean follow-up was 4.3. Almost 70,000 patients were treated with statin. So these are indeed very large population. However, if we compare this data with our meta-analysis we published in European Heart Journal several weeks ago, it was 4.2 million patients. But obviously, these were not patients' data meta-analysis, so there are some differences based on this. But if we look at these results, let's try to present them first. Here you have all those data. I will try to present it to you. So these are randomized controlled trials, and okay, here we have the first data. Okay, so altogether there was only 3% increase, in those patients in those trials when statins were compared to placebo, and 5% increased risk in those patients when we have high intensity versus moderate intensity statin therapy. So altogether, it was very low increase of statin myalgia or statin muscle pain or statin weakness, because the authors defined in this way statin-associated muscle symptoms. And this was probably the first bias, because if we look at this, if we look at the definition of statin intolerance, you know it very well that this is mainly associated with large symmetrical muscles. And in fact, when we talk about the weakness, simple weakness, if we talk about different muscle pains, this even in 70 to 90%, it might not be associated with with statin therapy. So it was the first thing that might cause some doubts concerning this results. What is more, if we look at the number of patients with myopathy observed in this study, it was promised. So it was less than 20 patients in each group with myopathy, and creatine kinase was, as far as I remember, I don't see these results here, but was evaluated and measured only in 0.3% of patients. So that is why it is another confirmation that these results do not reflect everyday clinical practice. Okay, what is more? It is critically important. In fact, if we look at the benefits of this data, after the first year, there was no increase of statin-associated muscle symptoms. So we know it very well that the higher risk of statin-associated muscle symptoms is usually after 3 to 6 months, within 3 to 6 months after statin administration and statin increase of dose. So, and after, if we have a statin associated muscle symptoms after a year, 2, 3, 4, 5, and so on, it is usually not associated with statin therapy, so it is nocebo-placebo effect, but it might be if it is associated with the impairment of kidney function, impairment of liver function, of new drugs that may cause interaction. So please always think about it, or with hypothyroidism, for example. What is more, if we look at the symptoms, this once again, please have a look. It was the most often observed. It was muscle pain and weakness. The prevalence, however, it is not prevalence. The frequency was about 11 per 1,000 person. Yes, so it was 1 patient per 15. So it is less than 1%. But please do not confuse it with the prevalence. It is not a prevalence of statin intolerance. It is the situation of the randomized controlled trials that were included, in which 16 per 19 patients with statin intolerance history were excluded. Statins with different muscle pain during washout period were excluded. Different conditions that might cause statin intolerance, such as chronic kidney disease, chronic liver disease, even diabetes in some patients, elderly age, hypothyroidism, were also within the exclusion criteria. So, and also drug-to-drug interactions. Those patients were optimally monitored within the design of the randomized controlled trial. So that is why those patients were also, there was also no drug-to-drug interaction observed in those patients. So that is why it is completely, these trials do not present everyday clinical practice. But on the other hand, if we present it in another way, if we are effective, if we may exclude nocebo-placebo effect using the PLIP algorithm, using the SAMS clinical index score, via optimization of the of the therapy of all concomitant diseases, via exclusion of the drug-to-drug interaction, we may have altogether only 1-2 patients per 100 with statin-associated muscle symptoms. It is hypothetical, obviously, but it is possible if we spend enough time for education, for using all those algorithms and all those methods I presented you for last probably 20-25 minutes. It is critically important based on this data. What is more, this is quite interesting. In our meta-analysis published in European Heart Journal, I showed you at least several different risk factors and conditions that might increase the risk of statin intolerance. Here, there is nothing. And it is only female gender that might be associated with 9% increased risk. In our paper, in our meta-analysis, it was 43% risk associated with female. So 11 female per 100 in comparison to 7 only men per 100 may have a statin intolerance. But please, once again, remember what I have just said. All those patients with those conditions were excluded because this statin, chronic kidney disease, liver disease, elderly patients, hypothyroidism, drug-to-drug interaction were within the exclusion criteria. So that is why those patients, those risk factors were insignificant. On the other hand, when we present it in an opposite way, if we are effective in the treatment of those diabetes, chronic kidney disease, obesity, those factors might not have significant influence on statin intolerance prevalence. So it is critically important also to remember. This analysis also confirmed our previous data from many different trials that high intensity statin therapy is associated with the higher risk. It was 8% here in comparison to low to moderate. It was 3% here. So that is why it is nothing special. So altogether, it's critically important analysis. I don't want to underweight these results because it wasn't fair to the authors because they did a great job. But we need to take into account, and I present all those issues in my commentary in the Lancet. That first of all, this meta-analysis confirmed that statin intolerance is overdiagnosed. Second, if we are effective with the education, exclusion of the nocebo-placebo effect, using all other recommendations, definitions, approved definition of statin intolerance, and all the methods of the suitable treatment, we may have only 1 to 2 patients with statin intolerance. Obviously, it is very, very difficult in everyday clinical practice because we usually have not enough time in order to take care of those patients, but please have a try because it is really worth to have all those patients treated with statin intolerance because it is simply associated with the significant reduction of cardiovascular outcomes and significant prolongation of lives of our patients. So once again, congratulations for the authors, obviously, but please remember that these papers do not reflect everyday clinical practice, and these results cannot be confused with the prevalence. But on the other hand, they show us the optimal situation that we may have if we are effective. Hopefully, I presented you everything about the statin intolerance, or at least the most important issues, especially the recent ones associated with the papers we published within my group and as well as published by the CTT collaboration, and once again, congratulations for this group. And if you have any question, I'm here to answer it. And the next meeting will be with the guest. I don't want to tell you which expert will be, but it will be one of the most recognized experts in the world, and we will discuss power of zero effect, whether it is important or not concerning the CAC score. And whether it may have any clinical relevance or not, whether it is cost effective and we may use it for all patients or for a very selective group of patients, whether we should follow the recent guidelines concerning the CAC score evaluation and measurement, or whether these guidelines should be updated. Stay tuned. Thank you so much. Good night.